Okay. So what I'm going to be talking about today are the results of the US IDNet survey of chronic granulomatous disease in that particular registry. Now, you've heard a lot about US IDNet already, and I just can't emphasize enough how incredibly invaluable that registry is for us to understand rare primary immunodeficiencies. And we've really used that tool to help with understanding more about chronic granulomatous disease. So I'm actually going to be doing the quality of life talk will be for another time. This is going to be really focused on more data related to antibiotic use, comorbidities, transplant, not transplant, et cetera. So the research motivation for this really stems from a IDF survey that was done in 2015. And so some of you were gracious enough to slog through 3 or 4 of these pages and provide us with some answers. And that was very, very insightful. And so from that survey, we learned that there were essentially 11 individuals with CGD ranging from 1 to 36 years of age. And the gender is male to female is listed there along with the genetics. Age of diagnosis occurred before the age of 2 in 72% of patients, and the race and ethnicity breakdown is listed there. So essentially what we found from this survey, we gathered a lot of important information with regard to comorbidity, medication use, but we also wanted to target certain areas that we felt had not really been addressed before and things that we as immunologists in the community really had questions about. And so ultimately it revealed that there were deficiencies in transition of care. There's significant variability in the use of antimicrobials. There's inconsistent use of interferon gamma, and there's variability in BMT consultation. So those were sort of our thoughts going into this survey, trying to understand what the actual picture looks like for CGD. And so I'll just touch upon this very briefly, and that is that transition of care to adulthood, to internal medicine care is something that is very rocky and something we need to be working on. And I want to assure you that we are working on improving transition of care for primary immune deficiency patients. So I'll leave it at that. But going on to some of the other results, with regard to infection prophylaxis, 100% were taking trimethoprim sulfa, which is very good. 82% were on an antifungal prophylaxis, so we'd like that number to be better. We can't expect it to be 100, but we want it as close to that as possible. And then with regard to interferon gamma therapy, 81% took interferon gamma at some point in time during their clinical course. 45% were currently taking interferon gamma. All of the patients receiving interferon gamma reported that their disease was well controlled or better. In terms of why interferon gamma is stopped for these patients, 1 was stopped for BMT, 3 stopped due to physician's decision, and there were more infections in the interferon gamma group than in the non-interferon gamma group. With regard to BMT, 1 patient actually underwent BMT at 9 months, and the parents believe that it was certainly worthwhile. 4 of the 10 remaining individuals had been seen by a BMT individual, so they had a BMT consult. And those patients tended to be younger, diagnosed earlier, and have less CGD symptoms than those peers not seen by BMT. So that was the result of the 2015 survey. I want to show this slide very briefly because it highlights the discrepancy in use of prophylactic antibiotics or belief in the use of prophylactic antibiotics vis-a-vis our European colleagues. Okay, so the European Society of Immunodeficiency here versus the Quad AI here, and this is sort of belief that prophylactic antibiotics are helpful. We see that 96% in the ESID group felt that it was helpful versus in the Quad AI, immunologists felt that it was, allergist immunologists felt it was 73.5% felt it was helpful. So that's a big problem. We need to improve that. We need to improve education. If we look at the breakdown of it, we see that those that practice general AI really had the lower numbers versus those that had more primary immune deficiency patients in their practice actually were more in favor of prophylactic antibiotics. So let's move now to the survey aim. So armed with all of that information, we really endeavored to determine what the current antifungal, antibiotic, and immunomodulator use is in CGD. We wanted to characterize the type of infections, identify the rate of comorbidities, look at the characteristics of those who underwent transplant, and then highlight any factors there were if there was a discrepancy in the use of medications. So this is the information. This is all new data that I'm presenting for the first time. So we had a really large sample size, 512 subjects. The mean age of diagnosis was 4.6 years, and the median age is 2. And the current average age is 33. 14.6% of the individuals in the registry are deceased, and the age there is 13.4 years. Female to male gender is 81 to 431, and the race and ethnicity breakdown is listed below. When we look at the genotypes, we see that the lion's share, of course, fall into the X-CGD group. But then it's really surprising to see that there's a group that is uncertain about their genotype. And that to me sounds, is very surprising. It's possible that those individuals were a bit older. I have to look at the data to see if they were maybe a bit older when genotyping and genetic studies were not as available as they are now. And then we have a small smattering of autosomal recessive conditions. And then with regard to antibiotic and antifungal use, now this is all comers. This is everybody in the registry, and this is everybody who answered these questions. They're all patients that had entries for this particular question. It turns out that 24.6% are on antifungals, 22.4% are on trimethoprim sulfa, and 15% were on an anti-staph medication. If you combine antifungal and anti-staph or trimethoprim sulfa, only 20% are on this combination of medications. Okay? There were 10% that were on other medications not particularly directed towards staph. With regard to recurrence of infection, we often wonder, if someone's had nocardia once, are they going to get it again, or Burkholderia? How does that really play out in the real world? And this is looking at recurrence of infection based on the type of organism, and we see that staph infections occur in 75% of individuals, followed by aspergillus at a little over 20%. But then recurrence of infections occurs with all of these organisms, and we can see that some individuals are getting 2, 3, and 4 distinct infections with organisms, and we see that happening quite a bit with staph and aspergillus. With regard to comorbidities, this is not really news to you in that there is a lot of GI comorbidity. Now, the discussion's really been centered around inflammatory bowel disease, and that really is a big problem. But if you look at the sort of total GI disease, including celiac, gastritis, perirectal disease, and gastric outlet obstruction, we see that 73% of the cohort have this particular complaint. And then with regard to kidney, GU, and bladder disease, it ends up being about 19 or 20%. With regards to some other comorbidities, these are non-infectious comorbidities, so restrictive lung disease, asthma, and then psychiatric conditions, including anxiety, depression, and then autoimmunity here. We were surprised to see this number actually as low as it is. This is excluding the GI autoimmunity and includes things like polyarteritis nodosa and lupus. So that was the breakdown there. Now let's talk about immunomodulator use. And once again, these are all comers. This is everybody who in the registry that responded to this particular question. And it turns out that steroids were used in 14.3% and interferon gamma in 31.3%. Now, we don't know if those individuals were on it continuously or how many times in their clinical course they actually started and stopped it, but that number to me seems a bit low. So moving on to comparing the different groups. So now we're looking at the group that was uncertain in terms of their genotype versus autosomal recessive versus X-linked. And we looked at the types of infections that we saw in these groups. And I've listed only the ones that were statistically significant, okay? When we do a post hoc analysis to try to figure out which group is the one that is significant and either is more or less, we see that the autosomal recessive group has more lung abscess, more other abscess aside from lung, liver, and brain, and also more Burkholderia and more viral infections like CMV and EBV. So that was a surprising finding to me, thinking about CGD and X-linked disorder being much more severe, but may not be the case. It may be that these individuals are not taking as much medication or perhaps not even getting the care that they need. So then we looked at the interferon gamma yes versus no group, and what we see are significant values here. When we look at the age of diagnosis, the interferon gamma group tends to be younger, 3.8 years at the time of diagnosis versus 5.3 years for the no group. In terms of genotype, it appears as though the X-linked group tends to use the interferon gamma more frequently than the uncertain or the autosomal recessive group. And then this final issue seems to be, was very surprising to me. There were fewer Hispanics in the interferon gamma group versus the non-interferon gamma group. So that certainly needs to be investigated further as to why we're seeing that disparity. And then we looked at further at the interferon gamma versus non-interferon gamma group. And it turned out to be that these individuals had more infections with regard to abscesses. They also had some, they're more likely to have neurologic and psychosocial issues. Now, certainly this is not causation, this is just association, and we can assume that these individuals were placed on the medication because they were having more infections. When we look at the transplant versus no transplant group, we don't see any more infections in the transplant group. So it didn't appear as though that was the reason why those individuals underwent transplant. However, if we look at some of the comorbidities, we do see some differences there. Looking at GI conditions, there were more conditions in the transplant group. There were more, GI conditions in the transplant group. There were more growth problems in the transplant group, more neurologic, psychosocial, and sinopulmonary, non-infectious sinopulmonary problems in the transplant group. So the conclusions are that there are a significant number of individuals with CGD who are not receiving standard of care prophylactic medications. We do see recurrence of infection of infectious organisms in CGD. There are high rates of comorbidities when looking at things in total. The BMT cohort did not have higher rates of infection, but did have higher rates of comorbidity, including GI disease. And the interferon gamma cohort had significantly lower rates of Hispanics in that group. So I'd like to just acknowledge the Immune Deficiency Foundation, certainly USIDNet, for allowing us to query their database, the UCSF CTSI, who assisted me in a lot of the data analysis, and of course all of you, patients and families, for participating. Thank you very much.